Hi, welcome to Nursing School Explained and this video on hypertonic IV fluids or solutions. Before we jump into looking into the details, let's review some basic principles that'll help you better understand the physiology and what we're actually looking at with patient care. So if we look at the basic principles here, first of all, there are certain fluid compartments. We have the intracellular fluid, which is inside the cell, and then we have the extracellular fluid, which are all the fluid compartments outside the cell. And the extracellular fluid is comprised of two different parts, which is the intravascular space as well as the interstitial space. And the interstitial space is the space between the intravascular and the intracellular fluid, where fluids move by osmosis back and forth, and then particles move by diffusion. So when we look at fluid shifts and IV fluid administration, we're always only looking at osmosis because we give the patient fluids, and that's what's going to cause fluid shifts if we give hyper or hypotonic solutions. And so osmosis only pertains to water shifting. So think about osmosis as H2O. And if we look at this in a beaker here with a semi-permeable membrane that basically represents the cell membrane, our body always strives for equilibrium, for homeostasis. And in this case, on the left side here, we have a higher concentration of particles and less water. And on the right side, we have a lower concentration of particles and more water. So when we look at osmosis, the water is going to shift from the higher concentration on the right to the lower concentration on the left, trying to equalize these two fluid compartments. And so the fluid moves from a higher to a lower concentration, and the H2O, osmosis, water moves. And here we have the normal serum osmolarity, which is the concentration of particles in a fluid, and in the serum that means the particles that are in our blood vessels. And that is 275 to 295 milliosmoles per liter. And depending on what our osmolarity is, we're either hydrated or dehydrated, or we're just normal in this case with normal concentrations of solutes. So how does this fluid shift and osmosis apply to IV solutions? So again, here we have our blood vessel and then the cell. And we can only administer fluids in the intravascular space. So now if we give the patient hypertonic IV solutions, meaning that they are more concentrated than the serum, and then like we talked about here, the body is going to try and shift and put this into equilibrium. So it's going to pull water out of the cells into that intravascular space and then get rid of it by diuresing it out. So in hypertonic solutions, fluid shifts out of the cell from that intracellular into the intravascular space. If you want a little bit more details on this principle, I have two videos that go more into the diffusion and osmosis and the different explanations on how that works into more depth. So for hypertonic IV solutions, again, they cause fluid or water to shift out of the cell. Now, when do we use them? So number one cause is if there's hyponatremia, a very low sodium level, and we'll talk about this here in a moment. The other use is when there is head trauma or cerebral edema, or which equals increased intracranial pressure. Because when the cells are swollen, there's a lot of edema, a lot of extra water in the cerebral cell that we want to move out, because most likely with cerebral edema, the patient has changes in levels of consciousness. They might have behavior issues, they might be agitated. And so we want to decrease the pressure in those cerebral cells by giving them intravascularly hypertonic solution. The water is going to shift out of the cells, hopefully making the patient's head injury better or less symptomatic. And so solutions that we use that are hypertonic is 3% sodium chloride. You probably recall that normal saline or isotonic saline is 0.9%. So this is greater than 3 times that percentage or concentration, and therefore it is a hypertonic solution. So now when there's hyponatremia, when there is less or low sodium in the serum, we give the patient a higher concentration of sodium to balance that out. Another solution that is hypertonic is D10, which is dextrose 10%. And this is commonly used in patients who receive parenteral nutrition, so through the IV, because for some reason their GI system is not allowing them to absorb nutrients. And D10 is something that we use in case the parenteral solution runs out, that we use very temporarily until we can get the next TPN going to make sure that the patient's blood sugar level doesn't drop. But that is a hypertonic solution, and we need to make sure that we check all the appropriate things with that we'll discuss in a moment. And then a couple of other solutions that include D5, which is 5% dextrose, so D5 0.9% sodium chloride, as well as D5 lactated ringer solution. And the special thing with D5 solutions is that in the bag, so if you're actually looking at the bag that contains the fluid, it is hypertonic because it contains the D5 and the normal saline, which by itself, the normal saline is just isotonic. Same with D5LR. D5, in addition to lactated ringers, which is isotonic in the bag, is a hypertonic solution. However, as soon as we start infusing these fluids into the patient's body, the D5 is used up because it is a source of nutrition, or glucose or dextrose, in this case sugar, for the body. So it's immediately going to be absorbed by the cells. So right away, as soon as it hits the patient's bloodstream, that D5 is used up, leaving us with the 0.9% sodium chloride, or the LR, which then means that in the body, it's actually an isotonic solutions, because right away we're burning off, or we're using up that D5. For nursing considerations for hypertonic IV fluids, we always have to check vital signs, blood pressure and heart rate, because we're giving them fluids at a certain rate, and that's going to cause that fluid shift out of the cells into that intravascular space. And whenever we add fluids to the intravascular space, we want to see how does that affect their blood pressure, and of course heart rate as well. And then we also want to check the patient's lung sounds, because they are at risk for fluid volume excess, because there's fluid shifts that occur here. We also want to check their sodium levels, because we most likely are given this for hyponatremia, or if we give it for head trauma, if it's a high concentration of sodium chloride, we'd certainly want to check the levels to see where we are, to make sure we're not tipping them over the point where they now go from hypo to hypernatremia. And then thirdly, or lastly, this type of solution is always administered at a slow rate and only at the IV pump. So normal IV maintenance fluids, such as normal saline or half normal saline hypotonic solutions, can be given anywhere from 30 to maybe up to 150 milliliters per hour, depending on the patient's situation. This hypertonic solution, because it affects the brain as well as their sodium levels, because it is so concentrated, is usually given only at a slow rate. So don't expect that to be more than maybe even 30 mLs per hour. If you see an order with 3% sodium chloride at 150 mLs an hour, then all the red flags should be going off, because things might shift really quickly, and then bad things can happen as the fluid shifts, and the patient might go into fluid overload, or it might affect their level of consciousness. So thank you for watching this video on Nursing School Explained. Please give me the thumbs up if you've enjoyed it. Also check out the other videos about hypotonic solutions as well as isotonic solutions, and also my videos about fluid volume deficit and excess that you can find in the fluid and electrolyte playlist. Thanks for watching. See you soon.